Okay, hi everyone, good morning, and welcome to the New York City Community Health Center Geriatrics Education Project, which is a joint project between the Community Healthcare Association of New York State, CHCANES, and the American Geriatric Society, AGS. Today's webinar is on medication management in older adults. My name is Amy Sigelka from the AGS staff, and I'm going to be the housekeeping person, so just a few notes. Our faculty members are going to present for 20 minutes each, after which we're going to conduct the Q&A session. You can type questions into the question and answer chat window on the right side of your screen at any point during the webinar. The faculty will get to as many questions as possible at the end of the presentation. If you have any technical questions or difficulties, you can send me a message in the chat window at any point during the webinar. You're also eligible to receive 1 hour of AMA Category 1 continuing medical education credit for participation in this webinar. In order to receive the credit, you must complete the post-test after the webinar is concluded. I'll review the details about that after the question and answer session. And now I'm going to pass this over to Dr. Donna Fick, our first speaker.
Okay, thank you very much.
You're ready.
Okay. Thank you very much, Amy. Good morning, everyone, and happy spring. At least there's spring here in Pennsylvania today, at least for a day. It is my pleasure to be asked to speak with colleagues from the New York community health centers and federally qualified health centers. I did have a little history with that when I was in Georgia. I did some work with diabetes and hemoglobin A1C from Thompsonville, Georgia. So it's a nice sort of reunion for me today. You do have my bio, but I'll tell you just briefly, I am a board-certified geriatric clinical nurse specialist. I've been board-certified through the ANCC since 1990. I love geriatrics, so you'll see a lot of my perspective comes from that. My other body of work has to do with delirium and delirium superimposed on dementia. And I'm in the midst, actually year 4, of 2 5-year clinical trials to decrease the severity and duration using non-drug approaches in persons with delirium, and that's funded by the National Institute of Health. So again, I'm pleased to be here today, and thank you for attending. You will note that myself and Dr. Fox have no conflict of interest for this content. And our objectives today really are fourfold, and that is to describe the 2012 Beers criteria and briefly some of the methods to look at commonly used medications, to talk about how they can actually inform clinical care, which is probably the most important thing and where we'll spend the most time. And then lastly, to talk about 3 common geriatric health problems: urinary incontinence, dementia, and sleep disorders, and how they relate in terms of safe medication use in older adults. So this is perhaps quite personal to me, but the creator of the Beers criteria, many of you may know, Mark Beers, passed away in 2009. So I'll just briefly say that the Beers criteria are really here because of Mark Beers' tremendous passion for improving medication use in older adults. And he was also a generous and kind mentor when I was involved in the 2003 updates of this. A couple of neat things is he was the first medical student to do a geriatric selective, and many of you may know he was a very interesting person, very active person personally, and he was also the editor-in-chief of the Merck Manual of Geriatrics. So Mark's passion continues in the AGS update. A little bit of history to the criteria because I think it'll help you appreciate how they continue to evolve and continue to improve. And you'll see at the end of this, we'll be open to your suggestions about how we can continue to improve them. So the Beers criteria, really, this is the 3rd sort of update. So they originally, the first time they came out was in 1991. And I think that was a paper with just Mark Beers and Joe Auslander. Many of you, I bet, know Joe. And they were medications to avoid in patients in nursing homes. So they really applied just to nursing home patients. 1997 was the first time that they were expanded to include all older adults. So community living, which I know many of you work in this population. And they were also adopted by CMS in 1999 for nursing home regulation. And I believe this was the TAG F29. 2003, really 2001, is when I became involved in them. I actually led this group with the generous help, again, of Mark Beers, and updates their criteria. And some of the things we did was modify the Delphi technique a little bit. So the first 3 times, really, we used a modified Delphi technique, which is really a consensus panel of experts to update these. And we also used a review of the literature. But in 2003, you may know that they were generalized and applied to parts of Medicare Part D and also to National Committee of Quality Assurance in the HEDIS measures. And then 2012, you'll hear a lot more about that, but I believe that there were a lot of rigorous improvements in 2012, and they were further adopted into the quality measures, really on a working much more closely with NCQA in the HEDIS measures. So the specific aim for 2012 when we updated these criteria were to use a comprehensive systematic review and grading of the evidence. And this is a little bit new. Again, excuse me, in the past we really used a modified Delphi technique, but this time, the things that we did differently I'll talk more about, but we graded the evidence. We used an interdisciplinary panel, which is not different. We've done that in all the updates. And we incorporated some exceptions. That's a little bit different. The other thing I'll say is that we were guided by the Institute of Medicine 2011 report on guideline development. And this is important because it really brought some transparency to the criteria, included a period for public comment. We actually had expert help and did a very comprehensive search of the literature. And we had over 25,000 citations. Something important I want you to note here, because it may be helpful for you during or after the criteria, is you can actually go on the AGS website and link to the evidence. So if we say avoid nitrofurantoin or benzodiazepines in older adults, you can actually click on the evidence that we reviewed. And we didn't put every single article there because it would have been overwhelming, but some of the main articles are there for you to say, okay, this is the evidence that they looked at in order to make these decisions as a group. We did have, as I said on the earlier slide, we had 11 voting members. As in past updates, the panel was interdisciplinary, comprised of 5 pharmacists, 4 physicians, and 2 advanced practice nurses, including myself. In the past, I was actually I was a facilitator and non-voting member. This time I was a voting member as co-chair with Todd Semla, who really was the leader of this group and, again, very passionate about this area. And then there were 3 non-voting members, representatives from CMS, Pharmacy Quality Alliance, and NCQA. And then I also want to acknowledge the AGS staff and the individuals that helped us with the literature search and the editing. So quickly, and I think this is an important piece because this really was something we had never done before with the criteria, and I'm sure we'll continue to evolve. But important change in this year's update was the increased rigor of the methodology used. For the first time, we really moved a little bit away from the sole Delphi technique, and we used this, again, guided by the Institute of Medicine, we used this American College of Physicians grade system following those recommendations. And I think it brought in evidence strength and transparency. So I'm not going to read these to you, but you'll see that we rated them by high quality, moderate, and low, and I believe you'll be able to get copies of these slides. But for instance, high evidence was well-designed, well-conducted studies. It might be 2 high-quality RCTs with no flaws, or consistent multiple observational studies with no flaws and large effects. Whereas moderate would be maybe there weren't RCTs, maybe there was only 1 trial with a lot of participants, or some consistent observational studies with moderate effects. So that's, again, how we graded them. We also gave them a strength of recommendation, and I'll just point out here that in some cases a drug could have a low or moderate evidence, and you'd say, well, why? And they could have a strong recommendation. And that's because, as many of you know, many times older adults are not included in clinical trials, or older adults with complexity and high burden of disease are not included in trials. The other thing is many of these drugs come into market very quickly, and these studies aren't done post-market because they're expensive. Another case might be if a drug is really old, and I think I'll be able to show you some of those examples in a minute. So in those cases, you might have evidence that's only moderate or low, but still have a strong recommendation because the risks are so high of the drug. Things that were not included in the Beers list I think is also important, because as a panelist and being involved with this for 10 years now, I'm often sent emails saying, why wasn't this included? And that is because there are some drugs, and some of the Budnitz drugs that you guys might be familiar with, like Coumadin and warfarin, those top 4 drugs that cause a lot of the problems, those risks aren't necessarily unique to the elderly. Very common, but not necessarily unique to the elderly. So we really looked at drugs that the risks were most unique to the elderly. Plus, there aren't really alternatives for those drugs. They're important, but people most of the time have to be on them. We also didn't look at drug-drug interactions. As you know, there are many other criteria, such as medication appropriateness index by Joe Hanlon, the stop-start criteria. But again, we couldn't be all things to all people. The other issue that comes up too is looking at alternatives, and this could be on the horizon, and it's a very important piece to have for the drugs to have an alternative. But we, at this point, haven't been listing what the alternatives are, because this is complex and often requires patient-specific and clinician judgment. So here we are to the tables. I want to point out a couple of things for the participants. In the paper, there are 9 different tables, and so the table numbering here that I give you are for the pocket cards, because I was told that everyone was given a pocket card. And so with your pocket card, which I hope you carry with you, there are really 3 main tables. Table 1 is drugs to avoid in older adults, period, except if, and that's this piece about this time we put some caveats that are really meant to help the clinician. So we do have some caveats there. Table 2 are drugs to avoid in certain disease or syndrome conditions or interactions. And that might be if they have the condition or if they're at high risk. And then table 3, again in your pocket card, because it's not the same in your paper, is a new category this time of drugs to be used with caution. So just note that those are a little differently numbered in the table. And these are some examples. I'm sure there'll be some questions about that, but I want to point out that in the pocket cards and in your paper, that we give the drug, for instance, nitrofurantoin, which is one that's been fairly controversial, and we give the rationale, which is that there's potential for pulmonary toxicity, there are safer alternatives available, lack of efficacy in patients with creatinine clearance less than 60, inadequate drug concentration in the urine, and then we may give a recommendation or a caveat, such as avoid for long-term suppression, avoid in patients with a creatinine clearance less than 60, and we give the quality of the evidence, which in this case was moderate, and the strength, which was strong. A couple of new ones, maybe to point out that might be new, is having insulin sliding scale was not on the 2003 criteria, so that's new. Glyburide is new, and benzodiazepines, regardless of dose, all short-acting, and then metoclopramide. So those are a couple that are new to the 2012 criteria that you might be taking note of. Again, this is another example. I wanted to show you one that had quality evidence was low and strength was strong, but these are all either high or moderate with a strong recommendation. I'll point out, like for benzodiazepines, again, we did begin to use more caveats this time, and this is also really new to 2012 criteria. So avoiding benzodiazepines for the treatment of insomnia, agitation, or delirium. Knowing that in some cases, such as anxiety, they may be appropriate. So I think there's not an example here, but I think, for instance, in your pocket cards, you'll see, like for desiccated thyroid, the quality evidence, we weren't actually able to find as many studies. This is an older drug. The quality evidence, I believe, on that one was low, but the strength and the recommendation was still strong. So that would be an example of that. So we'll move on in the considering time to Table 2. So again, Table 2 in your pocket cards are drug disease syndrome interactions. And here we give an example of syncope, drugs to avoid in syncope, and drugs to avoid in insomnia. So these are conditions that people either have or they're at high risk of. Some important changes this year. Oops, sorry, I'm going to go back to that. Some important changes this year that you might want to take note of as a clinician are the inclusion, again, which I know there's been some people taking note of this, perhaps some controversy, are the inclusion of SSRIs with falls or fractures, the inclusion of acetylcholinesterase inhibitors in syncope, several of the bladder medications in constipation, and then antihistamines in delirium. Again, we do have some caveats. For instance, with antipsychotics and delirium and dementia, there's the caveat of avoid unless the person is in danger of hurting themselves or others, which I believe is a pretty rare condition. These are the caveats. Again, this is something that's a little bit new, and these are example of several of the, a couple that are new. Actually, most of these are new. Z drugs for sleep, avoid them in chronic use. Again, the evidence points to that and clinical judgment. There we are, the antipsychotics, avoid unless non-drug treatments have failed or the individual is a threat to self or others. And I'm going to say here, because I don't think I've said that, is one of the things that the panel really struggled with is we wanted to include these caveats because everyone on the panel is a clinical expert and also has some academic expertise. So we realize that as a clinician, you need these caveats. But in doing that, we also sometimes shoot ourselves in the foot because it's then harder to apply them as a quality measure. So I'll just say that. It's this constant sort of balance between quality measure and clinical measure. And then the last table, which I talked about, was used with caution. What do I say about that? Again, that's new. These often, and I think dabigatran was a good example of this, is that these might be drugs that are new to the market, but they're being prescribed a lot. You know, the NSAIDs are a good example of that, and it's not till millions of people are taking them that we begin to see these problems, but the literature is not out there yet. So those are some, you know, and again, this is new, and some people would say, well, you know what, all drugs should be used with caution. So again, that's one we might talk about. Just quickly, I know most of you work in the community. This is Manju Beer, who was on our 2003 criteria. There are lots of papers out there. Actually, Joe Hanlon has one on that compares the 2003 to the 12. But I like Manju Beer's because it's only like 2 pages long, and it really gives you the cliff notes of some of the big changes this year and what's noteworthy and important as a clinician to think about. So you might look at her article. I thought she did a great job, and I know Manju. So I know most of you work in the community, but your patients do go to the ER and the hospital. I bridge across settings, and this is a real-world example from my weekly rounds. And I think it illustrates how we need to bridge the transition from home to hospital, and we need to work with all team members. So this is an 88-year-old patient falling at home, and the nurse puts a sticky note on the chart. Don't ask me why. When we have electronic medical records that says, look, the patient was taking Tylenol PM, which we know is diphenhydramine, at home for sleep and would like it or its equivalent ordered for here. So it's the importance of all players. Joe Agostini did a 1997 study that he published in JAGS, and when he tried to reduce the use of diphenhydramine and went back to the residents and said, why didn't you use my non-drug sleep protocol? They said, well, 32% of the time the nurses called us and wanted this drug, and we don't want to be called at 3 in the morning. So, you know, we really need to involve everybody. Because I'm running out of time too, I'm not going to talk a lot about this, but it's important to think about what we can do as clinicians. And I know that Dr. Fox will say much more about this and give some examples. Again, I work in the area of delirium, and our study focuses on non-drug approaches. One that I think is great is that if you haven't heard of it, is called TADA, and that's TADA. And this is from Joe Flaherty, if anyone wants it, I can give you the link after this talk. But it's very good in helping health professionals think about how they can tolerate behavioral issues and treat them without medication use. We also do weekly rounds. We lead interprofessional practice rounds with all team members. I probably have bought 200 pocket cards from AGS so that I could lead these rounds and give them to everyone I meet on the street and in the hospital. We also, in our study, have a non-drug sleep protocol. There's the reference for the Agostini study that I talked about, and also McDowell. Just having a 5-minute back rub, quiet music, and warm milk or decaffeinated tea has actually been shown to decrease the use of sedative hypnotics and to decrease the incidence of delirium in older adults. So this is not brain surgery. It's not rocket science. These are things that health professionals can do and family members can do. So again, the take home is that we did our best trying to balance this issue of making them clinically appropriate and also quality measures. I think it's important, especially with your community health centers, to think about how you can base a lot of this on what's happening with you locally. So maybe targeting your initiatives or your clinical efforts to the high prevalence, high severity meds, and thinking about this, being patient-centered care and realizing that it's only one part of appropriate prescribing. As you know, there are lots of other issues, which again, I think Dr. Fox will address some of those. There are some limitations. We realize that, and we're working, again, we want your input because we're working to, we have an ongoing SWAT team that's updating the literature as we go along. We're looking at this issue of alternatives. We know there are special populations within geriatrics that we need to think about, for instance, palliative care, end-of-life care, where some of these recommendations may not apply. So if you have evidence you think we should be looking at or ways that we can improve them in the future, we're very open to that. And with that, it's my pleasure to turn this over to Dr. Fox.
Thanks so much, Donna. I learned a lot from that. And I want to thank you all so much for taking time today to hear this. I think that changing practice is a really difficult thing to do. And what the purpose of my talk is to give you some simple tools, so it's kind of a simple talk, to use as you kind of hopefully move forward and bring others with you in moving away from drugs that are really bad for older adults. I actually, community health centers, or as I call them, FQHCs, are not really places where older adults tend to get care. Nationwide, about 8% of patients are on Medicare who get their care at federally qualified health centers. But I think that there might be a change. Actually, I guess I'm old enough to get the AARP magazine, and I got it the other day, and there was a whole article on what to do if you're uninsured. So it's really speaking to the younger group of the AARP. And the first place it said where you should go and get, if you're uninsured, health care is at community health centers or FQHCs. So I don't know if that's going to create an onslaught of people, but we're pretty busy as it is in our business. So I think that we do have to be up to the job, though. I think that since FQHCs haven't focused on older adults, that we haven't really kept our skills up. So am I not letting me move it forward yet?
I moved it forward. I think we may need to make you the presenter.
Okay. Is that you, Donna?
Yes. Amy, can you make Dr. Fox the presenter?
Okay, well, I'm going to keep talking while that goes on. So, yes, I'm Andrea Fox. I actually trained in the social medicine program at Montefiore Hospital in the Bronx, and then did actually my geriatrics fellowship also at Montefiore Hospital. I actually have been community-based in all my geriatrics work, creating home care programs, geriatric mobile units that go out. I worked at the VA for 10 years doing house calls. until I took this job at a brand new FQHC in 2006, so the Squirrel Hill Health Center. Our practice is focused on older adults, but also refugees and immigrants, so it's kind of a very unusual federally qualified health center. I spend 80% of my time seeing patients, both inpatient and outpatient. And last year I completed something called a Practice Change Fellowship, where my focus project was on creating a geriatric-friendly federally qualified health center. So I kind of can span both these words a little bit. Oh, okay. I'm not going to, and every slide I show, I'm not going to explain each of the side effects. The Beers criteria does a really good job at that. But these are the general things that happen to older adults with bad effects. Obviously, worse things can happen and more subtle things can happen. But confusion, which is a common side effect from a lot of the drugs I'm going to talk about, constipation or diarrhea, falls, as Donna had mentioned on almost every medication she mentioned, dehydration, and either agitation or lethargy. So basically, any change in an older adult, if a family member calls up and says they're just not themselves, you have to think about the medications. And I'm going to focus on these three areas, as was mentioned before. The first is urinary incontinence, and these are the most common drug prescribed for this is oxybutynin or ditropan. These are advertised widely on TV. People come in, they want to use them. But the medications do have a lot of side effects. They create dry mouth, they cause falls, they are very anticholinergic, so all the side effects that go along with that are going to happen in older adults. And then the other more important part is that it seems that they don't work that well when prescribed by themselves in the absence of both a thorough evaluation and proper treatment, and I'll talk about what that is. So one of the things that we have to make sure is that we know what is causing the incontinence. These medications are specifically used for urge incontinence. That's kind of lock and key incontinence when someone says, I felt the urge to go, but suddenly it just all came out. Very common. Stress incontinence is different. And with urge, it's usually large amounts of urine. With stress, that's different. We all know what that is, a cough, a sneeze. Sometimes just when it's very bad, even just movement can cause usually small leakages of urine. Overflow happens in men a lot who have big prostates, and that's a constant leakage. And giving these medications to those people is really very bad. And then there's secondary causes, constipation, other medications, infection, vaginal atrophy, all these other things that can cause urinary incontinence. So just kind of a quick run-through of when does this occur, how much is the leakage, what is the problem, is really important to figure out what's going on. I said, up here I call this needing to do something fast because I had a patient who came in the other day and she was like, you got to do something fast. And I understand that urge. She was demanding whatever drug that she had seen on TV. So the first thing that we tell people to do is toileting. Toileting is keeping your bladder empty. And I usually say, so how often do you have the problem, or how often do you find yourself running to the bathroom? And if they say, well, every 4 hours, I said, well, okay. So every 3 hours, I want you to just go to the bathroom. People have a real resistance to doing this. They don't like to be on a schedule like that. But it really sometimes works to completely eliminate the problem, right? Because if they don't have a full bladder, when they have that urge or when they get that increased pressure for stress, then there's not much urine there. And it's been shown over and over again that this helps a great deal. You can try then with the aid of Kegels, being properly taught how to do Kegels, when you do get that urge, to expand that amount of time. So when you get the urge, you do a Kegel, and then the urge can go away. Fluid management. Are people mostly having problems at night? Are they drinking a lot at night? Really making a cutoff time for drinking lots of fluids. Prevention of edema. So it's a very common thing, especially for nocturia, that people will say, when I go to sleep, I'm just peeing all night. And if you look at their legs in the evenings, their legs are edematous, either from too much sitting, too much salt, or maybe they have heart failure, whatever it is. And so I tell them that what they need to do is a few hours before they go to bed is to elevate their legs so much so that fluid gets mobilized before they go to sleep, or to wear supportive hose during the day so that the fluid doesn't collect down there so much. So this is really the now recommended treatment for especially urge incontinence, although it can help with stress as well, and that's biofeedback. And I'm sure that in the great city of New York, there is some place here that does this. There are at least 3 places that do it in Pittsburgh. And so what they do is that they actually connect electrodes to the perineum and correctly treat people, show people the correct way to do Kegels, and because a lot of people do them incorrectly. They also send them home with a bladder diary, and it seems that the bladder diary, keeping track of when you're wet and when you're dry, is the single most important thing that keeps people dry. It turns out that urinating is a lot to do with the brain, and that manipulating that or training it to be ways can make people continent again. Sometimes as an adjunct to the biofeedback and the toileting and the fluid management, people will add a medication like ditropan, and that can give some final benefit for people. So that's how we approach that. So benzodiazepines, Dr. Fick did talk quite a bit about benzodiazepines. A lot of patients come to me already on them who are already having side effects from them, but they are quite addictive to people, and older adults do get terribly dependent on them. Commonly, so these are medications like lorazepam, clonazepam. Alprazolam, which is Xanax, is to me kind of an absolute no-no in older adults, actually probably in anybody, except for kind of a one-time dose to get an MRI done if they get anxious, to go on an airplane if you're afraid of flying in an airplane. But other than that, alprazolam is like crack cocaine. It's so short-acting. It gives you this initial feeling of, oh, my anxiety is gone, and then it wears off and people get terrible rebound anxiety after that. So people end up on it all day, and it's very bad for people. As Dr. Fick said, these medications can be used for anxiety, but really you have to assess whether the person is really anxious, whether they're more depressed, and an SSRI might be more appropriate for them. Often what I do is when someone comes to me on these medications, they've been taking for sleep for 20 years or something. And people always say, oh, well, they're 80 now. What difference does it make? Well, they will continue to have worse side effects because their body continues to not be able to manage it so well. And as superimposed cognitive issues come on, then that might make it even worse. So I'll try to very, 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 and in a reassuring way, taper them off of those medications while starting an SSRI. And that has proven successful in my practice. These drugs aren't really meant for sleep, and they're not a good sleep drug, and they really should not be used in agitation from dementia. So this is the question of never. When are the exceptions? So as I said, a one-time dose for something scary that's going to happen. Sometimes in acute grief, when people really are just so upset and they can't sleep, sometimes giving them that opportunity to sleep is warranted. And then in palliative care, as Dr. Fick also mentioned, that they are used a lot in palliative care too, especially with breathlessness. So what do we use asleep? And I know I have Benadryl up there first, but that's a never used drug almost. A lot of people use diphenhydramine for all kinds of reasons. They say that their noses get stuffy at night, whatever, but they also are very drying, and they cause a lot of falls and a lot of hangovers. So, sometimes I'll say to an older adult, okay, well, if you want to keep using that Benadryl, that's okay, but then, you know what, you can't drive. And that often will convince them. That might not be such an issue in New York City, but where I live, it kind of works. Trazodone is marketed as and said to be a better drug with less hangover, but clearly even in older adults it's a problem. Zolpidem, as Dr. Fick said, can be used in acute situations. This might be the drug to use in the face of bereavement better than the benzos. But these medications too are addictive, and then you can become dependent on them. And I just want to make sure that everybody knows that for all patients now, all female patients, that the dosage was changed from 10 milligrams to 5 milligrams, because even in younger people, it was found that they had extended hangovers and that more car accidents were being caused and everything. So you can imagine what it's like for an older adult. So, again, taking a really good sleep history is important, right? Sometimes patients will come into me and they say, oh, I don't sleep at all. Well, what time do you get into bed? I get into bed at 8. And what time do you wake up? I wake up at 4 in the morning. Well, that's a lot of sleep, right? That's 8 hours of sleep. So tends to be a sleep phase shift for older adults, but they hate being up at 4 in the morning. So, working with them maybe to say it's okay to be up at 4, or to have them understand that they actually are getting enough sleep. I always ask people, are you tired the next day? And they'll go, well, no, not particularly. Do you nap during the day? No, I'm out busy and doing things. I said, well, then you must be getting enough sleep. There's something else going on. And Donna really talked about this idea of sleep hygiene, of having a routine before you go to sleep, of not having caffeine, of having something warm, of turning off the TV, of not doing anxiety-provoking things before you go to sleep. The other thing I really recommend for people is that during the day they go outside a little bit. Even though we've had a terrible weather in the East Coast, it actually is important for the eyeballs to see light during the day to help you sleep at night. A lot of older adults spend their days inside of dark apartments with the shades drawn, and they don't see light during the day, and there's no difference to them between day and night. So it's really important to get out, to move around a little bit, to expend some energy, and that helps. So medications for dementia, this is a highly controversial area even in geriatrics. Dementia is such a difficult illness. People say, well, we don't care, let's just try anything. But it turns out that even though when they were originally marketed, they were said to, improve cognition. We know that doesn't happen now. Then they said, well, maybe it makes people be a little brighter. Well, there's really been no evidence of that. It doesn't. The final thing is that it prevents people from going to a nursing home. Prolongs the time to nursing home. But in clinical practice, that actually has never been shown to be true. So there was an NIH consensus thing 2 years ago, and they said actually there are no medications or anything that does delay dementia. And the other part of it is that then, after all this marketing and all this time, it turns out that even though it was marketed that there were few side effects of these drugs, it turns out that there are quite a few side effects for these drugs. So they aren't harmless in patients. That's donepezil or Aricept. Memantine, what its action was said to be initially was that it prolonged your time through late dementia. And my question was, well, who wants to do that, right? I mean, when I'm demented and I'm in my late dementia, just let me get through it as fast as possible. But people actually who are taking these drugs, except in the very early states, have any choice about taking these meds. So it's really families making these decisions, and it's really families that we have to work with around whether to take these meds or not. There is a kind of push around diagnosing something called mild cognitive impairment, which is kind of an early dementia syndrome. About a third of these do not progress to dementia, but it's very hard to tell who is and who isn't. There was an effort to maybe prescribe these medicines for everybody, hoping that it would slow down the progression, and it turns out that it does not. So what do you do with these patients? They have this terrible disease. It's going to progress. The families are upset. How do we talk to them about it? And that's exactly what we have to do, is really talk about what the future holds, have them prepare for it, make sure they have an advance directive, evaluate what they can and can't do. In Britain, what they do with the medications is that they give certain qualified patients a 6-month trial, and if they continue to progress during that time, then they take them off the meds. Anybody in a nursing home has already failed that trial and should not be on these medicines. So antipsychotics, these are meds that we use in older adults mostly who have dementia and who have behavioral issues. So there are typical antipsychotics, haloperidol being the major one, and the atypicals, which we use risperidone, quetiapine, which is Seroquel. And the trouble with these medications is a large study came out a few years ago. Besides that, they don't work that well for older adults who have behavioral issues. But they also, it turns out, lead to an early death. Again, in balancing, when families come to me and say, I can't sleep, they're so agitated, they're wandering, I say, well, we can try these medications. I don't know if they'll help, but you have to understand that they may lead to early death. And that sometimes is an okay thing for some people, right? But I think, as probably Donna is more of an expert on than I am, you really have to sit down and figure out why the person is agitated. Sometimes families agitate people. Sometimes something in the environment is agitating someone. Sometimes pain is agitating someone. So to really dig deep, which does take some time, is important before initiating any of these medications. But again, as I said, people need, the caregivers need sleep, balance possible side effects with family needs. Sometimes people, because they're so agitated, they don't eat, and sometimes giving them a little tiny dose, and I mean like 0.5 of something, or of Haldol, it calms them down enough to actually eat, which makes the families feel better too. And again, physical activity during the day, getting them outside, moving them around, exposing them to air also helps with agitation. So in general, this is just kind of my general approaches to medication use in older adults. First of all, which I don't have here, but which I think Dr. Fick would agree with, and I would say, is that to minimize the number of drugs people are on. That's number one. Then consider non-pharmacological approaches first. And as you've seen in the presentations, we both have that kind of approach. Start at low doses and go slow. Okay. Even with things like Bactrim, in an older adult, I never prescribe Bactrim double strength. It's always single strength. A lot of clinicians don't even know that single strength exists. But with all medications, we start at very, very low doses. As Dr. Fick said, caution with medications that are new to the market. It takes me about 2 or 3 years for a medication to be on the market for me to use it in one of my older adults. Medication reconciliation. Make sure that when families or the patient comes in, that they tell you both what they're taking over the counter, any other kind of medications or treatments or vitamins or other substances that they're using. And also to know if they're seeing other physicians who are prescribing them other meds that you don't even know about. That is really important. I think once we get the improved communication with our pharmacies through electronic health records, that's going to improve. That's going to make things much better. And then anytime someone has some change in them, as I said at the beginning, is that you have to think that it may be the medications. Always think that. And this is it getting easy. This is the downhill side. If you look in the middle there, that's my husband bungee jumping in New Zealand last month, 60 years old. There he is. And that was both hard and easy. And that's what I expect you guys to feel also with your new approaches to taking care of older adults. Thanks. Now, we got no questions by typing, so we're going to open up all your phones so that you can ask questions over the phone. Any questions?
Not really. Really good presentation. Hello? Yes.
Any questions, either verbally or written?
No, not really.
I think probably both of us could address this, so I'll start. I won't address the Aricept issue as much as I will the non-drug approach. I think one of the things that Dr. Fox commented on is, it's really a family approach. So if they really understand that there are side effects with the drugs and they think that it's helping, then there might be cases where you would leave them on it. But again, realize that there are side effects, there's cost to the drug, and a lot of the evidence really shows that it's not helpful. We actually have a clinical trial that's going on right now for, if you look at the NIH consensus report, again, they said nothing works. The only thing that there was a little bit of impact on is activity, physical activity. So I do think there's enough there to at least say that may improve memory, it may improve quality of life and well-being, even in persons with dementia. We had a gentleman I saw the other day that had a PhD and a mini mental score of 15/30, and he was walking 3 miles a day. And the wife really felt like that improved his memory. So I think if they're able to be physically active, if not, there's also a small emerging amount of evidence. Again, we're in the 4th year of a clinical trial on this, where we give people with delirium superimposed on dementia 30 minutes of very simple cognitive stimulation for up to 30 days. And we've actually published that. I can share that with you. And these are very simple activities that family members could do, that a nurse aide could do. In our trial, we have trained staff doing that. We actually have a video that will show you how to do that. And I guess there's a follow-up question about PCP or psych, and I'll perhaps let Dr. Fox now address. That would be a couple of comments, is that there are, non-drug approaches that may improve memory. And then the behavior issues, again, I come from the background that I think most behavior in persons with dementia, and I also have a son that has Down syndrome and has some of these behaviors, most of them are needs-based. And it's the inability to communicate what those needs are. So working with the family with some of those techniques like TADA to figure out what's the need behind the behavior, I think is really important. And again, the single most risk of having drug problems is being on too many drugs. So if you can minimize some of these, that's a good thing. Dr. Fox?
Yeah, so this is, as I said, a really struggle problem. Certainly I have patients who are on Aricept for this reason, that somebody else started them. And then the family is scared to take them off, or the patient is scared to take them off. Certainly, when you're given a medication by someone and said, well, this is the medication to treat that, sometimes there is kind of a placebo effect that you might get better. I don't rip these drugs off of people. If they're not having side effects and they really feel like they're doing well, I'll let them continue it. But as the person's dementia progresses, it's clear that the medication won't be doing its job. If they truly have Alzheimer's disease, their disease will progress with Aricept or without it. And as it progresses, I keep with the family, it's progressing. That means the drug isn't doing its job. Maybe it's time to stop it now. So it's just a constant working with the family. There really has been no study, although, there's this idea that maybe it slows down the progression. There's been really no evidence that it improves cognition. And so anyway, that would be my approach. But most patients, most family members do come in saying, no, it never worked. I've never seen a difference. And if before starting it, I give them the lecture about, like what Dr. Fick just said, they will say, well, then I don't see there's a reason to do it. So should it be managed by a PCP? I would hope that mostly it can be. I don't think that psychiatry has any other magical drugs in their back pocket that they're going to use. Sometimes agitation. We have a psychiatrist in our office, and I will, to manage those drug medications, if I feel they need them, then I will send them to the psychiatrist. But sometimes I'll do that to work with the families, right, to help them deal with these issues a little better. And I totally support what Dr. Fick said about the exercise. I think it's really important for all of us, but particularly in this setting. You're welcome. Is there any? Okay, so there's a question up top here about controlling hypertension, diabetes, or hyperlipidemia. And do you want me to try and answer that first, Donna?
I don't even see the question, so if you don't mind reading.
It's actually up above.
Okay.
From Hafiz Maja.
Maybe you could read it for
Okay,
panelists.
so is there any body of evidence on the usefulness of controlling chronic conditions such as hypertension, diabetes, or hyperlipidemia, specifically in the 75 age group? Quite frequently, our patients end up on polypharmacy simply because their blood pressure or blood sugars or lipids are so difficult to control. So yes, actually, there is an emerging and somewhat confusing bunch of evidence that is coming out on this, particularly saying that tight control of any of these chronic problems leads to poor outcomes in older adults. So if you think about it, both the effects of hypertension, diabetes, and hyperlipidemia occur for 20 years from where you start, right? Most older adults aren't going to be alive that long. So that it turns out that tight control of these things actually leads to more problems. So if for a while there was this idea that a blood pressure of 140/90 wasn't good enough. And I know because I do these UDS, I have to do the UDS statistics with you guys, and, if we have a lot of older adults, their kind of evaluation of us hasn't caught up with this, so it's really a problem. But I'm not going to kill my patients over that. So, and for a while it was saying, no, now it's 120/70. Well, older adults are like falling on the floor all the time. So they have now, there's been some research that says that keeping it at 140/90 is okay. And the same is true for diabetes, that the hemoglobin A1C tight control is not on for older adults. That older adults are in much more danger of hypoglycemia than in moderate hyperglycemia. So that hemoglobin A1Cs, even between 8 and 9, are now considered somewhat okay, as long as the patient isn't symptomatic from their high blood sugars, and then you do have to control them a little tighter. But as is on the list, glyburide, which causes a lot of hypoglycemia in older adults, is not to be used. And metformin, while it's a wonderful drug, really has to be watched carefully in older adults because of the renal situation. And the same is true. The high lipids is a little more murky. I'm not going for a cholesterol of 150 in my older adults. There has been some positive literature that says that you do have lower lipids, that you do have fewer. But now, again, a lot of research on statins shows that there's a lot of bad side effects. There's a lot of good effects, but there's also a lot of bad side effects. And if someone suddenly is really aching and stiff and can't get out, you have to look towards their statins. Did you have something to say, Donna?
Not really. I think that's your expertise more than mine. I just thought of two things. One is that I'd agree. For 3 years, I did case management just in the home in California, and at least anecdotally, one of the biggest reasons I saw people falling was overly tight control of blood pressure. So, those people were really over-medicated and falling all the time, and sometimes with serious consequences. And then I'd also call everyone's attention to the new campaign called Choosing Wisely. Mm-hmm. This is by the American Board of Internal Medicine, and then the American Geriatric Society also have a list of 5 things that providers and patients should question in older adults. And, of course, one of those is using medications to achieve a hemoglobin A1C less than 7.5%. So, and they also talk, just like you did, about why that's the case. And again, this is not a never, never, never. You use your clinical judgment, but it's a list of things that people really should question. And for us to think really about this sort of less is more approach. So,
yeah. And the recommendation for sliding scale insulin also is really important. I really try and have almost none of my older adults on insulin at all. It is really a difficult issue on how they give it to themselves and the correct use of it and how it makes them gain weight. And, there's all kinds of things. So that this looser control idea has been really helpful in terms of that.
Did you see there's a question about mirtazapine?
Yeah. I think we have a couple minutes left. I don't think I'm seeking all the questions, but I see one that says, does Aricept have any benefit on mood and behavior in severely demented patients or patients with severe dementia? Not that I know of, but
I know that there was marketing around that. There's a lot of off-label marketing around that, but there has been really no good evidence around that.
Yeah, I don't think the evidence.
In terms of mirtazapine, any comments? I think sometimes it is useful in low doses, again, for people who might be depressed, but also for people who've lost weight. It really helps people gain weight, including older adults. But again, it does have sedative side effects that you have to watch for. So, you have to just watch for it. Right?
Amy, did you want to wrap it up and do any housekeeping? I think
it looks like we are pretty much done. So I just want to maybe thank everybody again. And just a note to the participants. As I've mentioned earlier, we need you to take a post-test in order to receive the CME credit for the presentation today. Once I close out the event, you should be immediately directed to the post-test page on SurveyMonkey. If you're viewing the webinar and you're not signed into the software, you'll get an email immediately after with the same link. If you have any problems at all, you can contact me or your staff contact at Chicanes if you have any questions or trouble with the post-test or any additional questions at all. And thank you for your participation in today's webinar. We really look forward to hearing your feedback. And that should be it. Thanks, everybody.
All right, thank you.
Is everybody gone?